There's a test your doctor can order tomorrow that has a real chance of putting you in worse shape than you are right now. Not because something goes wrong in the dramatic sense, not an accident, not negligence, just a test that was designed for a younger body running inside an older one, and the math stops working. I've been a physician for over 22 years, and I want to be honest with you about something the medical system rarely slows down long enough to say. More testing is not always better medicine. More testing is sometimes the thing that breaks what wasn't fully broken yet. Today, I'm going to walk you through 5 intestinal tests that carry serious underreported risks for people over 60. Not because these tests are useless, some of them are extraordinary tools, but there is a version of each one that I would personally decline for the right patient at the wrong time. And after today, you'll know exactly what I mean by that. Let me start with something that doesn't get said enough. The gastrointestinal tract in a body over 60 is not the same organ it was at 40. The muscle layers thin. The nerves lose some of their speed. The tissue lining becomes more fragile in specific ways that imaging can miss entirely. We have a term in medicine, procedural tolerance. It means the body's ability to go through a diagnostic intervention and come out on the other side without a net loss. And procedural tolerance is not evenly distributed across age groups. I've had patients come to me after a routine bowel prep who lost 8 pounds of fluid in 36 hours and never fully recovered their kidney function. Not from disease, from preparation. That is not rare, it is underreported. And the reason it stays underreported is that nobody connects the procedure to what happens 3 weeks later. The complication doesn't announce itself with a timestamp. So here's the distinction I need you to carry with you through this entire video. There's a difference between a test that finds something and a test that finds something at a cost your body cannot afford to pay. Those are 2 completely different outcomes, and that difference is going to matter a great deal in the next few minutes. Test number 1, high-volume colonoscopy prep in patients with kidney disease. Now I need to say something clearly before we go further. Colonoscopies save lives. Colorectal cancer is one of the most preventable cancers we have, and I am not suggesting anyone abandon screening entirely. What I am telling you is this: the preparation is where the danger lives, not the procedure. Standard high-volume bowel prep requires flushing the entire gastrointestinal system in a 12 to 24-hour window. For a 50-year-old with healthy kidneys, the body rebalances within a day or two. For a 72-year-old with stage 2 chronic kidney disease, that same prep triggers something called osmotic nephropathy. The kidneys can't clear the phosphate load fast enough, and crystals form in the kidney tubules. We are talking about permanent structural damage from a diagnostic preparation. A study published in the American Journal of Kidney Diseases found that elderly patients with pre-existing kidney impairment who used phosphate-based prep had measurably worse kidney function at 6-month follow-up compared to baseline, not return to baseline, worse than baseline. So what does an informed patient do with that? Ask your gastroenterologist this before you agree to any prep. What is your protocol for low-volume or alternative preparation in patients with reduced kidney function? That question exists, that alternative exists, and in many cases it's equally effective. Test number 2, aggressive small bowel capsule endoscopy with motility disorders. This test sounds almost elegant. You swallow a capsule the size of a large vitamin. It contains a camera and photographs the entire length of your small intestine as it travels through. No sedation, no incision. How could that possibly go wrong? Here's how. In patients over 60, particularly those with a history of diverticular disease, prior abdominal surgeries, or undiagnosed partial obstructions, which are far more common in this age group than most people realize, the capsule can stop moving, not slow down, stop. The technical term is capsule retention, and when retention happens, the only way to retrieve it is surgery, a surgical procedure to remove a diagnostic camera. In an older patient who had no symptoms before the test, the published retention rate in high-risk elderly populations ranges from 3% to 26%, depending on the presence of underlying obstructive lesions. Even at the low end, That is a meaningful number for a test ordered to find a problem you might not have had. And here's what frustrates me most. There is a patency capsule, a dissolvable test capsule that can be swallowed first to confirm the bowel is clear before committing to the diagnostic capsule. Many patients are never offered it. Test number 3. Repeated CT colonography in patients with high radiation burden. CT colonography, virtual colonoscopy, is often presented to patients as the gentler option. No sedation, no instrument inside the body, just a scan. And for many patients, that's completely accurate. But here's what the gentle framing leaves out. A standard CT colonography delivers approximately 6 to 10 millisieverts of ionizing radiation. That is roughly equivalent to 3 to 5 years of background radiation from the environment compressed into a single afternoon. For a patient who has had multiple abdominal CT scans in their lifetime, and after 60, most people have had several, the cumulative dose begins to matter in ways that are not tracked between different hospitals, different imaging centers, or different ordering physicians. Nobody is connecting the dots for you. You are accumulating a radiation ledger that no single doctor is reading in full. A landmark analysis published in The Lancet Oncology estimated that in patients over 65 who have had 5 or more abdominal CT examinations, the estimated lifetime attributable cancer risk becomes statistically non-negligible. Not terrifying, but not zero either. And it is almost never discussed at the time of ordering. So ask your physician directly. Given my imaging history across all my providers, is there a lower radiation or radiation-free alternative for my specific clinical question? Test number 4. Endoscopic mucosal resection in severely frail patients. This one requires a distinction first. Standard polypectomy, removing a small polyp during a colonoscopy, is generally safe and often essential. I am not talking about that. I am talking about endoscopic mucosal resection, the removal of large, flat, or complex lesions from the bowel wall using specialized cutting and lifting techniques. It is a more aggressive procedure, and in the wrong patient, the risk profile changes dramatically. In patients over 75 with 3 or more comorbidities, cardiovascular disease, anticoagulation therapy, significant anemia, endoscopic mucosal resection carries a substantially elevated risk of delayed hemorrhage. Not immediate bleeding that the endoscopist can see and control. Delayed, meaning the patient goes home and the bleeding starts 24 to 96 hours later. The rate of clinically significant delayed hemorrhage in high-risk elderly patients ranges from 9% to 17%. In a 78-year-old on blood thinners for a cardiac stent, 9% is not a small number. Add to that the perforation risk, a hole in the bowel wall that becomes an immediate surgical emergency, and the picture becomes genuinely complex. Here is what I would want for any patient in this situation. A frailty assessment before the decision is made, not just a review of the chart, an actual functional assessment, grip strength, gait speed, cognitive status. Some centers now require this before scheduling complex procedures in patients over 75. That is exactly right. That is medicine being careful on purpose. Test number 5, hydrogen breath testing with aggressive dietary protocols in patients with cardiac arrhythmias. This one catches people off guard more than any other. Hydrogen breath testing is used to diagnose small intestinal bacterial overgrowth, SIBO, and certain carbohydrate malabsorption conditions. The test itself seems harmless. You drink a sugar solution, you breathe into a tube, repeat every 15 minutes for 2 to 3 hours. Here's what the setup leaves out. The preparatory dietary protocol requires a 12 to 24-hour period of extreme carbohydrate restriction, followed by consuming a specific fermentable sugar load. This triggers rapid bacterial fermentation in the gut. In patients with documented cardiac arrhythmias, atrial fibrillation, supraventricular tachycardia, the electrolyte fluctuations caused by this dietary pattern, combined with the gas-producing fermentation response, can trigger vagal nerve stimulation sufficient to precipitate an arrhythmic episode. There are documented case reports. This is not theoretical. A patient following instructions exactly as given, no deviation, no error, can trigger a cardiac event from a diagnostic protocol they never questioned because it seemed too mild to question. So what do you do? First, if you have any history of arrhythmia, palpitations, or are on antiarrhythmic medication, that information must be in front of your ordering gastroenterologist before this test is scheduled. Second, any test that requires a significant preparatory change to what you eat, what you drink, or what medications you hold deserves a cardiac safety review for anyone over 60 with a cardiac history. Full stop. Now, here's what I don't want for you after watching this. I don't want you to walk into your next gastroenterology appointment with a printed checklist, arms crossed, prepared for conflict. That is not advocacy. That is defensiveness dressed up as information. What I want is something different. I want you to walk in as a participant, informed, direct, and specific. Before any intestinal test, planned, recommended, or urgently suggested, there are 4 questions that every patient over 60 should ask. Write these down. Question 1. What specifically happens if we delay this test by 30 to 60 days while I optimize my kidney function, my hydration status, and my medication review? A good physician will give you an honest answer, and if the answer is nothing urgent changes in the next 60 days, you have time. Question 2. Is there a lower burden alternative that addresses the same clinical question for my specific age and health profile? Stool DNA testing, fecal immunochemical tests, low residue prep protocols, patency capsule confirmation, the options that have emerged in the last decade are genuinely powerful for the right patient. Question 3. What does recovery from the preparation and the procedure realistically look like for someone with my kidney function, my cardiac history, and my current anticoagulation status? Not the average 58-year-old in the clinical trial. You, your electrolytes, your baseline, your living situation, and whether someone is with you for the 48 hours afterward. Question 4, and this is the one most patients never ask. What is your personal rate of significant complications for this specific procedure in patients over 70? Endoscopists and radiologists track this. They know their complication rates. A confident, honest specialist will tell you without hesitation. If they seem thrown by the question, that itself is a data point you needed. Before I get to the most important thing I'll say today, I want to leave you with something genuinely hopeful. Non-invasive stool-based screening has become remarkably accurate. Fecal immunochemical testing and stool DNA panels can detect early colorectal cancer and high-risk polyps with sensitivity levels that compete directly with optical colonoscopy. For a frail 78-year-old who cannot safely tolerate PrEP, this is not a compromise. This is an equivalent path. And beyond testing itself, optimized gut health through targeted probiotic protocols, dietary anti-inflammatory management, and supervised monitoring can reduce the clinical urgency of many diagnostic workups that previously had no alternative. The gut wants to signal. Our job as physicians is sometimes to listen to what it's already telling us before we reach for a scope. Let me tell you about a patient. I'll call him Arthur. 69 years old, retired contractor, built things with his hands his entire life, and was proud of every joint he'd ever cut clean. He came to me after 2 different gastroenterologists had recommended a full colonoscopy with high-volume phosphate prep. Same recommendation twice, no discussion of alternatives. Arthur had stage 3 chronic kidney disease and a heart that had been managed for atrial fibrillation for 6 years. He wasn't scared of tests, he was scared of the prep. He told me, "The last time I did that prep, I felt wrong for 3 months afterward, and nobody could tell me why." When I reviewed Arthur's full profile, his kidney function, his arrhythmia management, his medication list, I sat down with him for a real conversation, not a 15-minute slot, a real one. The data for his specific risk profile showed that a stool DNA test combined with a CT colonography using the lowest dose protocol available, with a full renal protection plan, gave us equivalent surveillance sensitivity with a fraction of the prep burden. His cardiologist was looped in before anything was scheduled. He chose that path. That was 14 months ago. His kidney function has not declined. His arrhythmia has not been destabilized by a prep event. And last month, he sent me a photograph of a kitchen renovation he just finished for his daughter's new house. Cabinets he built himself, level and flush. And exactly right. Here is what I need you to understand. This is the single most important thing I will say today. A diagnostic recommendation is not a sentence. It is the opening of a negotiation. You are not a body being processed through a system. You are a person with a history, a physiology, and a future. And you have the absolute right to ask what this test costs your specific body before you agree to it. The physician holds the order pad, but you hold the consent. And that consent, given with full information and open eyes, is the most powerful diagnostic tool in this entire conversation. Let's bring it together. 5 intestinal tests that carry serious underreported risks for people over 60. High-volume colonoscopy prep in patients with kidney disease. Capsule endoscopy in patients with motility disorders. Repeated CT colonography with high cumulative radiation burden. Endoscopic mucosal resection in severely frail patients. And hydrogen breath testing in patients with cardiac arrhythmias. None of this means avoid all testing. Testing saves lives. I have ordered every one of these tests when the clinical picture called for it. The message is this: be a participant, not a passenger. Ask the hard questions before you agree. Request the alternatives. Know your own numbers, your kidney function, your arrhythmia history, your cumulative scan burden. Bring them to the appointment. They belong in the room. Take care of yourselves. Stay precise about your own health. You deserve a physician who explains not just what the test finds, but what the test costs. And that conversation, honest and unhurried, is exactly where good medicine lives. Everything I've shared today is general medical information grounded in published research and clinical practice. Every person's situation is unique. Before making any decision about diagnostic testing or treatment, please have a full, direct conversation with your own physician or specialist. They know your history, they know your body,